Hi, this is Nurse Marcia. Welcome to Part 5 of our Pediatrics NCLEX-RN series. Today, we're focusing on cardiac and circulatory conditions including congenital heart defects, Kawasaki disease, and more. Let's explore these 25 high-yield questions, answers, and comprehensive rationales to master the critical thinking skills needed for the NCLEX. Let's get started. Question 1. A 4-year-old child with a history of cyanosis during feeding has been observed squatting during play. Which congenital heart defect is most likely? A. Coarctation of the aorta. B. Tetralogy of Fallot. C. Ventricular septal defect. D. Patent ductus arteriosus. Answer: B. Tetralogy of Fallot. Rationale: Tetralogy of Fallot (TOF) is a cyanotic defect characterized by 4 structural abnormalities: ventricular septal defect, pulmonary stenosis, right ventricular hypertrophy, and an overriding aorta. Cyanosis during feeding and squatting during play are hallmark signs of TOF. Squatting increases systemic vascular resistance, which reduces right-to-left shunting and improves oxygenation. Coarctation of the aorta and PDA are acyanotic defects that do not present with cyanotic spells. VSD causes left-to-right shunting, which does not result in cyanosis unless Eisenmenger syndrome develops. Question 2. A newborn presents with cyanosis that does not improve with oxygen therapy. Which congenital heart defect should the nurse suspect? A. Transposition of the great arteries. B. Atrial septal defect. C. Coarctation of the aorta. D. Patent ductus arteriosus. Answer: A. Transposition of the great arteries. Rationale: in transposition of the great arteries (TGA), the pulmonary artery and aorta are switched, creating 2 separate circulations. Oxygenated blood fails to enter systemic circulation, causing profound cyanosis unresponsive to oxygen therapy. ASD and PDA are acyanotic and usually do not present with oxygen-resistant cyanosis. Coarctation of the aorta is primarily associated with upper extremity hypertension and lower extremity hypotension, not cyanosis. Question 3. A 6-week-old infant with a loud, continuous machine-like murmur and bounding pulses is diagnosed with a congenital heart defect. Which condition is most likely? A. Ventricular septal defect. B. Patent ductus arteriosus. C. Atrial septal defect. D. Tetralogy of Fallot. Answer: B. Patent ductus arteriosus. Rationale: patent ductus arteriosus (PDA) presents with a machine-like murmur due to continuous blood flow from the aorta to the pulmonary artery. Bounding pulses occur because of widened pulse pressure caused by diastolic runoff of blood through the ductus. VSD and ASD typically present with soft systolic murmurs, while TOF is cyanotic and does not produce these findings. Question 4. A child diagnosed with a ventricular septal defect is at risk for which complication if left untreated? A. Pulmonary hypertension. B. Aortic aneurysm. C. Right-sided heart failure. D. Mitral valve regurgitation. Answer: A. Pulmonary hypertension. Rationale: VSD causes left-to-right shunting, which increases pulmonary blood flow. Prolonged overcirculation leads to pulmonary hypertension and may progress to Eisenmenger syndrome. Aortic aneurysm and mitral valve regurgitation are not direct complications of VSD. Right-sided heart failure may occur secondary to pulmonary hypertension but is not the primary risk. Question 5. Which congenital heart defect presents with diminished lower extremity pulses and elevated blood pressure in the upper extremities? A. Tetralogy of Fallot. B. Coarctation of the aorta. C. Transposition of the great arteries. D. Ventricular septal defect. Answer: B. Coarctation of the aorta. Rationale: coarctation of the aorta is a narrowing of the aortic arch, typically near the ductus arteriosus. Creates increased blood pressure in the upper body and reduced blood flow to the lower extremities, resulting in weak or absent femoral pulses. TOF and TGA are cyanotic defects, and VSD does not cause pulse discrepancies. Question 6. A child with Kawasaki disease is in the acute phase. Which clinical manifestations are expected? A. Fever, non-purulent conjunctivitis and strawberry tongue. B. Fever, polyarthritis and erythema marginatum. C. Cyanosis, poor feeding and hypotension. D. Desquamation of hands and coronary aneurysms. Answer: A. Fever, non-purulent conjunctivitis and strawberry tongue. Rationale: in the acute phase of Kawasaki disease, clinical findings include prolonged fever, non-purulent conjunctivitis, strawberry tongue, and rash. Polyarthritis and erythema marginatum are associated with rheumatic fever, not Kawasaki disease. Cyanosis and hypotension are not typical findings. Desquamation and coronary complications occur in the subacute or convalescent phases. Question 7. True or false? Intravenous immunoglobulin IVIG is the primary treatment during the acute phase of Kawasaki disease to reduce the risk of coronary artery complications. Answer: true. Rationale: IVIG, given within the first 10 days of illness, significantly reduces inflammation and lowers the risk of coronary artery aneurysms. It is combined with high-dose aspirin for antiplatelet and anti-inflammatory effects. Question 8. A nurse is caring for a child recovering from Kawasaki disease. Which complication is the priority to monitor during the convalescent phase? A. Myocarditis. B. Coronary artery aneurysm. C. Rheumatic valve disease. D. Pulmonary hypertension. Answer: B. Coronary artery aneurysm. Rationale: coronary artery aneurysms are the most serious complication of Kawasaki disease, particularly in the convalescent phase. Myocarditis occurs in the acute phase. Rheumatic valve disease and pulmonary hypertension are unrelated. Question 9. Which intervention is the priority for preventing rheumatic fever in children? A. Administering antibiotics for streptococcal pharyngitis. B. Monitoring for signs of polyarthritis. C. Providing prophylactic aspirin therapy. D. Encouraging vaccinations against strep infections. Answer: A. Administering antibiotics for streptococcal pharyngitis. Rationale: prompt treatment of group A streptococcal gas infections with antibiotics prevents rheumatic fever. Monitoring for symptoms and aspirin therapy are secondary measures. Vaccines are not available for gas. Question 10. True or false? Rheumatic fever commonly results in permanent damage to the mitral valve. Answer: true. Rationale: rheumatic fever often leads to mitral valve stenosis or regurgitation due to autoimmune inflammation of the heart valves. This damage is a hallmark of rheumatic heart disease. Question 11. A nurse auscultates a murmur in a child with a history of streptococcal infection. The murmur is best heard at the apex of the heart and is described as a mid-diastolic rumbling. Which condition does this suggest? A. Aortic regurgitation. B. Mitral stenosis. C. Ventricular septal defect. D. Patent ductus arteriosus. Answer: B. Mitral stenosis. Rationale: mitral stenosis results from scarring of the mitral valve due to rheumatic fever, leading to a mid-diastolic rumbling murmur best heard at the apex. Aortic regurgitation produces a diastolic murmur heard at the left sternal border. VSD and PDA cause systolic murmurs, not diastolic. Question 12. True or false? Heart murmurs that occur during diastole in children are always considered pathological and warrant further evaluation. Answer: true. Rationale: diastolic murmurs in children are typically caused by structural heart abnormalities, such as valvular stenosis or regurgitation, and require further investigation via echocardiography. Question 13. A child with heart failure is admitted with tachycardia, hepatomegaly, and poor feeding. Which nursing intervention is the priority? A. Administer oxygen therapy. B. Restrict fluid intake. C. Provide high-calorie nutrition. D. Monitor weight daily. Answer: A. Administer oxygen therapy. Rationale: oxygen therapy reduces the workload of the heart and improves oxygenation in heart failure. While fluid restriction and nutritional support are important, addressing immediate oxygenation needs is the priority. Question 14. A 2-month-old presents with irritability, diaphoresis during feeding, and tachypnea. The nurse suspects heart failure. What additional findings would confirm this diagnosis? A. Hepatomegaly and peripheral edema. B. Cyanosis and clubbing. C. Weight loss and decreased urine output. D. Bradycardia and weak pulses. Answer: hepatomegaly and peripheral edema. Rationale: hepatomegaly results from systemic venous congestion, and peripheral edema is due to fluid retention, both hallmark signs of pediatric heart failure. Cyanosis and clubbing are late findings in cyanotic defects, not initial signs of heart failure. Question 15. A 10-year-old is diagnosed with hypertension secondary to coarctation of the aorta. Which clinical finding is most consistent with this condition? A. Upper extremity hypotension. B. Delayed capillary refill in the hands. C. Weak femoral pulses. D. Continuous murmur over the pulmonic area. Answer: C. Weak femoral pulses. Rationale: coarctation of the aorta causes diminished blood flow to the lower extremities, resulting in weak femoral pulses and blood pressure discrepancies between the upper and lower extremities. Hypotension and delayed capillary refill in the upper extremities are not expected findings. Question 16. True or false? Secondary hypertension in children is most commonly caused by renal disease. Answer: true. Rationale: renal disease is the most common cause of secondary hypertension in children, including conditions like glomerulonephritis and renal artery stenosis. Question 17. A 7-year-old with hypertension is prescribed an angiotensin-converting enzyme, ACE inhibitor. What side effect should the nurse monitor? A. Bradycardia. B. Hyperkalemia. C. Hyponatremia. D. Hypokalemia. Answer: B. Hyperkalemia. Rationale: ACE inhibitors block the renin-angiotensin-aldosterone system, reducing aldosterone levels and causing potassium retention. This can lead to hyperkalemia. Question 18. A child with Kawasaki disease receives IVIG therapy. What is the primary purpose of this treatment? A. Reduce the risk of coronary artery aneurysms. B. Treat bacterial infection causing the disease. C. Resolve fever and conjunctivitis. D. Promote rapid desquamation. Answer: A. Reduce the risk of coronary artery aneurysms. Rationale: IVIG is an anti-inflammatory treatment used to prevent coronary artery complications. Kawasaki disease is not caused by a bacterial infection, and its hallmark fever and desquamation are secondary concerns. Question 19. True or false? Aspirin therapy in Kawasaki disease is discontinued immediately once the fever subsides. Answer: false. Rationale: aspirin therapy is continued in low doses after the fever resolves to provide antiplatelet effects, reducing the risk of thrombus formation in inflamed coronary arteries. Question 20. Which of the following are major manifestations of rheumatic fever? A. Sydenham chorea. B. Erythema marginatum. C. Migratory polyarthritis. D. Subcutaneous nodules. Answer: A, B, C, D. Rationale: the Jones criteria include major manifestations that indicate systemic inflammation caused by rheumatic fever. Sydenham chorea: involuntary, jerky movements primarily affecting the face and upper extremities. Erythema marginatum: ring-shaped rash with clear centers primarily on the trunk and proximal limbs. Migratory polyarthritis: large joints, knees, elbows are inflamed and the pain migrates between joints. Subcutaneous nodules: firm, painless lumps over bony prominences or tendons, often seen with carditis. Question 21. A child recovering from rheumatic fever is prescribed monthly penicillin injections. What is the primary goal of this prophylactic treatment? A. Prevent recurrence of streptococcal infection. B. Treat existing carditis. C. Reduce symptoms of polyarthritis. D. Prevent long-term neurological complications. Answer: A. Prevent recurrence of streptococcal infection. Rationale: Monthly penicillin prophylaxis prevents group streptococcal gas infections, which can trigger a recurrence of rheumatic fever. While carditis and polyarthritis are treated during acute episodes, prophylaxis focuses on preventing further damage, particularly to the heart valves. Question 22. A nurse auscultates a holosystolic murmur in an infant with failure to thrive and frequent respiratory infections. Which congenital heart defect is most likely? Atrial septal defect. B. Coarctation of the aorta. C. Ventricular septal defect. D. Patent ductus arteriosus. Answer: C. Ventricular septal defect. Rationale: VSD presents with a holosystolic murmur best heard at the lower left sternal border. The left-to-right shunting increases pulmonary blood flow, leading to symptoms like failure to thrive and frequent respiratory infections. ASD murmurs are typically soft and systolic. PDA produces a continuous murmur, and coarctation causes pulse and blood pressure discrepancies. Question 23. A child with heart failure is admitted with hepatomegaly, poor feeding, and tachycardia. Which intervention is the nurse's priority? A. Administer diuretics as prescribed. B. Provide high-calorie formula. C. Monitor oxygen saturation levels. D. Position the child in semi-Fowler's position. Answer: C. Monitor oxygen saturation levels. Rationale: monitoring and improving oxygen saturation is the priority to ensure tissue oxygenation and reduce cardiac workload. While diuretics, high-calorie nutrition, and proper positioning are essential, addressing oxygenation first is critical in acute heart failure. Question 24. True or false? Pulmonary hypertension is a common long-term complication of untreated left-to-right shunting congenital heart defects. Answer: true. Rationale: untreated left-to-right shunting defects, e.g. VSD, PDA, cause increased pulmonary blood flow and pressure, leading to pulmonary hypertension. Chronic pulmonary hypertension may result in Eisenmenger syndrome if the shunt reverses direction. Question 25. A 6-week-old infant is diagnosed with patent ductus arteriosus, PDA, and is prescribed indomethacin. What is the primary purpose of this medication? A. Close the ductus arteriosus. B. Improve systemic oxygenation. C. Reduce pulmonary hypertension. D. Manage fluid retention. Answer: A. Close the ductus arteriosus. Rationale: indomethacin is a prostaglandin inhibitor that promotes closure of the ductus arteriosus, a structure that normally closes shortly after birth. While systemic oxygenation and pulmonary hypertension may improve indirectly, the primary goal is ductal closure. Fluid retention is managed with diuretics if necessary. That's it for Part 5 of our Pediatrics NCLEX-RN series on cardiac and circulatory conditions. Don't forget to like, subscribe, and share if you found this helpful. Stay tuned for Part 6, Neurological and Developmental Disorders. This is Nurse Marcia, wishing you the best of luck on your NCLEX journey. See you next time.